All right. Well, good evening, everyone. Now that 7:05 is coming past, I want to thank you so much for being here for this New York Emergency Medicine Student Council event featuring Dr. James Salway and Dr. Laura Lavicoli. We have a great presentation set for you, followed by some time for Q&A. And again, we appreciate you being here despite the weather being absolutely lovely outside, as Dr. Salway mentioned before. So what I'm going to do to start is just introduce our two speakers, and then I'll share some slides and have them get going to talk not only about New York City Health and Hospitals as a system, but also specifically about the emergency management and response functions within that system and some specific and particular events that they're going to highlight around how the system, as well as specific hospitals within it, responded to all kinds of disasters and disruptions to care. So to go ahead and start, we have Dr. Laura Lavicoli here, who is the Chief Medical Officer at Elmhurst Hospital right now. She's also a professor of emergency medicine at Mount Sinai and formerly served as the Assistant Vice President for Emergency Management across the system-wide New York City Health and Hospitals Emergency Management Office. And she also, as a recent stalking of her LinkedIn showed, earned her MBA at LSU, which I did not realize, but wanted to congratulate her on. Additionally, we have Dr. James Salway here, who is the Senior Director for Emergency Management at the system-wide Central Office of Emergency Management for New York City Health and Hospitals. He's also a practicing emergency medicine physician at Kings County Hospital, a clinical assistant professor of emergency medicine at Cornell, and he previously did a fellowship as well as a European master's in disaster medicine. So I'll keep those summaries there. Would love to have you guys add on anything else that you want to highlight in your own journeys, but I will go ahead and share my slides here. Let me see. Share. Okay, and slideshow. So can everybody see these right now? All right, great. Well, we'll go ahead and get started with the slides. I'll turn it over to them, and then we'll have some time for Q&A at the end.
All right, so I have to start because you know how you at the beginning of most talks you're supposed to do disclosures, right? Do I have any financial this or financial that? My only disclosure is that headshot is now about 15 years old. So at some point I'm gonna have to update that because that's like 1 year out of residency when I was full of like, boyish enthusiasm. At some point that's got to go because no one's gonna buy it any longer, man.
You haven't aged a day. I don't know what you're talking about.
Oh, you shut your mouth. All right, so why don't I just I'll kick things off. This is going to be kind of the run of show. What we're going to do is just briefly start talking a little bit about what exactly New York City Health and Hospitals is, because that may not be necessarily an organization that you guys are super familiar with. Talk a little bit about the emergency management kind of structure that we have as a system. And then, as Ryan discussed, the touch on kind of certain responses and kind of incidents that we've had to deal with in the most recent past related to emergency management. And then from there, talking a little bit also about the different types of trainings that are available at New York City Health and Hospitals with an emphasis on emergency medicine, because that's all of our background, and that's obviously what you guys are here interested in as well. And then we'll leave some time for Q&A, whatever you guys want to bring up. So Ryan, you mind next slide for me? So let's talk about what New York City Health and Hospitals is. So you guys may be more familiar with the individual kind of hospitals more than necessarily the actual system. So what New York City Health and Hospitals is it's the city's public benefit corporation, sure, but essentially it's the city's system of hospitals. It is the largest municipal healthcare center in the system in the United States. So that means that, like, out of all the different kind of groups of hospitals that are out there, we're talking about ones that are run by any city, this is the largest. It was founded in 1969, right? It includes 11 acute care hospitals. So ones that you may be familiar with, Lincoln Hospital. Well, let's just go through them all. Lincoln, Harlem, Jacobi, Metropolitan, Elmhurst, Queens Hospital, North Central Bronx, Kings County Hospital, Bellevue Hospital, What used to be called Coney Island is now South Brooklyn Health, Woodhull. I think that's it. I forgot to start counting on my fingers. Now I lost track. But if I said 11 names, then there we go, 11 hospitals. Beyond that, there's about 30 Gotham Health Centers. So these are kind of like clinics, so primary healthcare clinics, 5 post-acute facilities, and 1 long-term, what we call an LTAC, long-term acute care facility. So the big thing that sets us apart, and the thing that we really pride ourselves on here at New York City Health and Hospitals is the mission, right? So, as it says here, right? What is that? This is essentially, we're saying that we want to treat and make sure that all New Yorkers, no matter what their immigration status, no matter what their insurance status, no matter what their ethnic background, no matter about anything, frankly, have access to the highest level of care that we can provide. And we really focus on doing that in a very dignified and respectful way, which is something I think that sets us apart from perhaps some other, we'll say, for-profit systems. Next slide, man. So as you may imagine, when we're talking about, 11 different hospitals who treat around, I think it's about 1.4 million New Yorkers a year, and all these other kind of different clinics and health services, things can be very complicated. So we have a central office, kind of a headquarters, if you will, which is down in Financial District. And I work for Central Office Emergency Management, which Laura used to head. And so really what the focus of this is, we have emergency management and emergency preparedness coordinators at each individual hospital, but we need to be able to coordinate between this kind of massive system, right? When things come up, how do we make sure that we're utilizing the resources in the best way that we can when we're talking about such a gigantic kind of footprint, right? We have about 45,000 employees. I already mentioned the patients that we see. We're talking about a very complicated and a very large operation. So central office emergency management is kind of responsible for certain aspects of this. We're responsible for creating and initiating the emergency operations plan, which is kind of essentially an all hazards approach to how, whether it's coastal flooding, it's power outage, it's a pandemic, active shooter, etc. How do we get the right people kind of turned on, if you will, to be working and working towards fixing whatever the issue that's come up. We hold a number of exercises that occur both at individual sites and throughout the entire system. We also have a training academy where we essentially teach the next generation of emergency preparedness coordinators and clinicians as well, background in emergency management. We work on COOP, which is in a way kind of like the continuity of operations, how things will continue depending on what services go out. A huge focus recently, especially since the pandemic, has been on situational awareness. A lot of this has been really only able to occur through the use of kind of technology. Our system just came onto a single EMR just prior to COVID, and that really helped us kind of get an understanding of where things stand at our facilities at any time, right? Having a finger on the pulse of how many patients we have in an emergency department, how many patients we're having showing up who are testing positive for influenza A, right? What does that mean? How do we respond to that? So being aware of really what's going on with our patients and within our facilities is a huge component of this. And then we also do a lot of work outside of New York City itself. We have good relations with the United Nations. We actually have done several trainings at the United Nations, working with their CMOs, focusing on things like special pathogens, specifically Ebola, Marburg, and other kind of viral hemorrhagic fevers, as well as other kind of exotic pathogens that are coming up. part of it is to prepare them, part of it is to prepare ourselves. So that way, we know that New York City, as being, I guess, a hub and a gateway to the United States and to lots of other places, one of the first places that are going to see these diseases when they start to spread. And often they will show up in, a small clinic in Elmhurst, Queens. And, we may have to then, make sure that our staff there is ready to respond. So it's kind of a lot of the roles of what we do from a central aspect. Laura, I'll turn it over to you.
Great. So this is some pictures from, the beginning of the pandemic in wave 1 that probably might be familiar from the media. The New York Times, showing everybody in their full PPE, caring for a COVID patient that's clearly in distress or extremis. The middle one is a picture of our trauma center entrance. During wave 1 of COVID, we had, so Elmhurst Hospital was what we call the epicenter of the epicenter. So it really kind of started in the US at Elmhurst and then hit the whole health system pretty quickly after that. And we had ambulances lined up down the street to drop off patients. Patients lined up down the street in what I called the Disney line, kind of sneaking around and down the block, waiting to get into the hospital. And then there wasn't an inch of space on the floors for any of the, we found a way to bring more patients in always. And I'll talk a little bit about some of those protocols, but it was pretty much like a light switch. We saw one patient and then suddenly we were overrun with patients before we even knew what was going on and before the rest of the city even knew what was going on. I remember riding my bike home down 2nd Avenue in the beginning of it. One of the rare times I was actually going home during that first wave and seeing people, out on the streets at the bars, still congregating, thinking, oh my gosh, like they have no idea what's about to hit them. And it was really hard to honestly wrap your head around all of that. So March 13th, New York City Health and Hospitals treats the first confirmed COVID-19 patient. And on March 25th, it was in the news that, crisis intensifies, 13 patients passed away in 24 hours at New York City Health and Hospitals, Elmhurst, which was definitely a crisis moment for us. Bottom left is the Disney line I was talking about. So this is, we had to set up some barriers and people lined up down the street and kind of snaked around and then went down the block. But they are very diligently keeping their 6 feet distance, which I commend them for. We would go up and down that line with a pulse ox and just, assess people, check their oxygen level, pull them in. Anybody who looked like they were an extremis or they were hypoxic, so that, we were able to care for them quicker. And then, people who looked like they were more stable had to wait a little bit longer to be seen, but we definitely saw everybody. I didn't turn anybody away, never would. Next slide. So how is this different from other crises that we have seen probably in all of our lifetimes and many lifetimes even before us? The volume, we've never seen volumes to this extent. And the acuity, so how sick the patients were, they came in, waited too long to come in, and came in really, really, really sick. We tried to do everything we could to keep them off of ventilators because once they were on the ventilators, it usually didn't result in a good outcome. Very difficult to ventilate these patients. But we learned how to prone them. We learned how to do a lot of things to keep them off the ventilators. And then we learned very unique strategies for ventilator support. As time went on, we met with our colleagues in Singapore, in Italy, really across the world, and asked them, what they were seeing and what best practice was working for them. And then the duration, I mean, it just, went on week after week after week, and nobody really knew when we were going to get a reprieve and patients were going to start to decline in volume. So we've never seen, any of this in combination to this degree in our past experience of disasters that we have responded to. So some of the lessons learned, I think at a facility level, a big lesson learned was how to make decisions. So you really had to gather the experts, gather your infectious disease experts, your infection prevention experts, your critical care experts, your environmental services experts, your facilities experts, everybody, from an operation standpoint and a clinical standpoint, and get them in a room and decide, how are we going to handle not only the clinical aspect of what we're seeing, but the operational aspect. When they first came in, we had to figure out how we would initially try to contain patients who were clearly infected clinically in a certain area of the emergency department. That area had to expand because that area quickly became overrun with patients, soon became the entire emergency department. We decided to declare a hot zone, and nobody could go in without full personal protective equipment on, and had to take it off when they left for the day, and had to stay in it all day. Now that was a little bit novel at the time, because that was at the time when this was so new that administration was telling us that we weren't supposed to wear masks in front of patients because it was scaring them too much. But we decided, we made this decision, we were gonna, become a full hot zone, and work with our facilities people on bringing in air scrubbers and diverting ducts, and putting up walls and diverting oxygen and all kinds of things in order to be able to, again, accommodate the volumes that we were seeing. So you gather the experts, you triage, you think of the decision that's going to benefit the most, because you want to, be able to save as many lives as you can. You match your resources with the availability, you move quickly, and you implement the decision. So one of the things that I noticed is that people are really paralyzed to make decisions. So you had to pull the trigger. You had to just make the decision, implement it, reassess often, and overall, gather the sound advice, listen to the experts, but lead with your head and your gut, and just redirect when something wasn't going exactly the way you wanted it to, and go another path. At the system level, we learned that there's obligation to meet the needs of all critically ill patients, and we needed to really expand beyond the walls of one single institution and work together as a health system. So break down those silos around, each of the siloed facilities, work together, develop a coordinated intersystem of transfers, of patients, of staff, of resources, so that we could create a better economy of expertise in clinical care. And that was, I think, the biggest thing that we learned, is really how to work together as a system. I think in the future, we really need to plan for a citywide centralized command center, that this wouldn't just involve health and hospitals coordinating within our own system, but coordinating within the region and other health systems. So kind of like a break the glass command center that would be able to assess where are their beds, where is their staff, where are their resources, and be able to move that around in another crisis to this level, so that if, hospital system X has capacity, hospital system Y has some, extra staff, hospital system Z has the resources that can be distributed, so that we can save as many lives as a region as we possibly can. And then the other one is data sharing, and James talked a little bit about this, but consistent situational awareness, data sharing to manage and maintain data across all silos. I mean, we really stood up data sharing quickly within the system, but I think this also needs to be a regional data sharing so that we all can see what's going on in the whole region. And this will help to mitigate misinformation, disinformation, and lack of user-friendly information, and help to save, again, as many lives as we can in a future disaster. And then finally, from the national level, I mean, I think we just saw advice and guidances that came out a little too late and didn't quite work operationally to what we were seeing. So we really needed to bring the public health experts together with the operational experts and the clinical experts, so that everybody is putting their heads together from all these three different buckets and putting out guidances quickly. And most important, I think we learned, honestly, that we need a strong and sustainable safety net system. So New York City Health and Hospitals is a safety net system, and this was really the biggest lesson from all the waves, but particularly wave one of the pandemic, that neglect of a public health system results in healthcare disparities and social inequities, and that disinvestment in public health and public health systems really there were cracks there when COVID hit that became huge valleys, and we really owe it to our communities to invest in them so that they are strong and durable and can sustain the next big disaster. And that is my lessons learned from COVID. Next, on to you, James.
Yeah, so one of the other kind of more recent crises, I think, that New York City Health and Hospitals is helping New York City manage is the recent surges in asylum seekers and migrants that have come to New York from the southern states for crossing over the southern border. This really kind of first started off back in October 2022, when what started with a couple of buses sent up by the Texas governor kind of turned into a much more regular kind of flow of individuals coming up, looking for opportunities, looking for assistance, looking for ways to kind of start their lives over in the United States and in New York. And this really fell upon the city government to kind of try and figure out how to deal with this kind of wave of immigration that was kind of essentially just came out of nowhere again, like a light switch. So the City Hall, in combination with NYCEM, which is New York City Emergency Management, and New York City Health and Hospitals, started setting up a series of what were referred to as HERCs initially. This is the Humanitarian Emergency Response and Relief Centers. It started off with initially the idea was to set up a kind of a large tent shelter up in the Bronx, and then various different iterations of that have occurred depending on kind of the number of patients that were coming in and the sites that were available. Now many of these sites are in underused hotels spread throughout the city, but there are also some kind of large congregate settings in Brooklyn and in the Bronx as well that were set up. But all these patients, all these, I guess, migrant seekers, asylum seekers, they all needed medical care, right? In some way or another. And this kind of fell upon New York City Health and Hospitals to really set up and make sure that we were able to provide for all these patients who were looking and needed things done. A lot of it was primary care. So we're talking about screenings for diseases, vaccinations in kids, the depression screenings. A lot of this was operational things. So trying to enroll individuals into health insurance here, so that way they could be taken care of. We had over 100,000 emergency department visits, some clinic visits, but overwhelmingly emergency department visits from asylum seekers in the year 2022. And then also had 500 plus births that occurred, not in the actual in the HERCs, but rather for patients who were then moved over to New York City Health and Hospitals facilities. So, we've kind of, again, had to look at the situation and try to kind of respond in the most, humane, but also rapid way that we possibly could. We've set up medical sites and medical care at many of the actual hotel sites, and then also found ways to then expedite care for the patients if they need to be transferred over. We've made sure that we have, staff on site that can speak all the different languages that the asylum seekers are coming in with, and making sure that we can provide kind of culturally competent care, both at that sites and at our hospitals when they come across. So again, it's been a really interesting, but I think also a really I think the right thing to do, kind of a challenge that we were not expecting to see. You know, at no point in emergency management were we really anticipating having to set up, you know, medical care for essentially an entire city moving to a city. And I think, you know, overall, we've managed to provide really incredible care to these people who many are fleeing, you know, really traumatic situations and haven't been able to get care in their home countries for a significant period of time. So this is one of the responses that I personally am very proud to be affiliated with, that New York City Health and Hospitals has really taken on. Next slide, Ryan.
Great. This one, the labor strike, I mean, all of this, you know, we've all collaborated on very closely, but this one was the resident healthcare labor action, which was the first of labor action providers in, I think it was 40 years. So James, at the time, this was at Elmhurst Hospital. You know, as the deputy CMO at the time, and James as director of its central office for emergency management. We were working hand in hand, and he was actually there with me at my side through this whole thing. We were managing it together, and Brian has helped us tremendously in some of the pre-work and now the post-work from the event. So at first, when we got wind, maybe a month, 6 weeks before it actually happened, that there were some grumblings that there could possibly be a strike in the future. We started gathering information from the services that would be affected. So this was our internal medicine service, our behavioral health service, and our pediatric service, primarily. Some impact on pediatric emergency department, neurology, and our CCU and medical intensive care unit. Those were much smaller impacts, though. But for the first three that I mentioned, we're talking, you know, planning for 180 providers literally not showing up if they called a strike. So they'd be working on, say, you know, Monday, and then Tuesday, suddenly 180 people that would have showed up to work weren't going to be showing up. So this is what we were heading into and planning for. We worked and created really intricate templates for each department of what the coverage could be with what they could do internally. Maybe scaling down services, redeploying staff, people who wanted to do overtime. We looked at what gaps were then there and reached out to our sister facilities to get some of those gaps covered, reached out to Mount Sinai partners to get some of those gaps covered. And then probably too late in the game, we probably should have done it earlier. We reached out to our locums agencies to see if there were locums. We thought it would take too long. In the end, it would have been a smart move, because what they ended up doing was pulling locums in the system who are already credentialed and pulling them to Elmhurst to help cover gaps. So that's the internal coverage plan. We also worked on decreasing demand of patients who are coming in. So trying to keep the demand as low as possible. This included patient transfers. So we worked with our central office colleagues and our sister facilities. Oh, actually, that's the level loading. Sorry. Patient transfers, we're specifically talking about, prearranging non-emergent transfers to be accepted by our sister facilities. So this is, part of the level loading piece of this. Just knowing where our sister facilities can take certain things and prearranging that we would be able to move patients to those facilities We had our care experience teams go around to patients in the emergency department and patients on the floors and ask them if they were willing to be transferred in order to create more space at Elmhurst for a decreased amount of staff that would be able to take care of patients. We also worked on rapid patient discharge. So we had teams going around to the patients who were admitted, and this really focused on the healthy patients waiting for discharge who were held up by some administrative procedures. They were healthy enough to go home, didn't really require care in the next 96 hours. Case management and social work really helped us with this to go through and discharge any patients that could be discharged with some extra home support. And we also used patient admission decisions that we altered. So patients that would normally get admitted to one of these 3 services that we could kind of offload to another service. This was particularly done with medicine patients, internal medicine patients that the surgical services could take on a temporary basis. And they really stood up, showed up to the plate for us and admitted a ton of patients for our internal medicine colleagues in order to offload them as much as they could with their decreased workforce. We definitely had to focus on internal messaging. It was, I think, the most important thing, or one of the biggest important things, is communication in a disaster. And you really have to keep everybody on the same page. It keeps everybody calm, for one. And you also want everybody with the same situational awareness. I mean, the more I don't think there's ever a thing in over communicating in a disaster. So we used alertus mass notification. So this is like the ticker at the bottom of all of our computers to send out messages. We sent out the daily webmaster notifications, daily emails, screensaver updates, daily text messages. We blasted out to all staff. Besides having the continuous leadership huddles, we met 3 times a day with leadership, clinical, operational, executive leadership. We used WhatsApp messaging to keep everybody on the same page. We distributed summary documents 3 times a day to everybody, again, to keep everybody on the same page. With also protocols around, what we were doing, how were we handling what we were seeing. External messaging, I mean, this is really important. These are keeping your community advisory boards up to date, so they can be calm and know that the patients are being taken care of, and everybody is everybody has showed up and we're able to still continue for the most part normal operations. New York State Department of Health showed up at our doors and was walking the floors every day to make sure that care was being delivered adequately. We had to have daily conversations with Department of Health around census and staffing. We had to communicate with citywide leaders around what was going on. Joint Commission also inquired about Elmhurst plans in order to continue to ensure high quality care during the strike and how we were able to do that. We had to provide Department of Health and Joint Commission and a lot of city agencies with extensive planning documents around mitigation strategies and what we were doing to make sure that everybody was safe. We definitely collaborated with external partners. Again, New York State Department of Health, locums agencies. Again, we could have probably done that a little bit earlier than we did. Our NYSEM, New York City Emergency Management colleagues definitely were on board to help in any way they could. Greater New York Health Association, we were partnering with Sydney EMS for New York City, having daily communication with them around, they clearly said they didn't want to put us on diversion, but had we really needed it, they would have done it for us. And we were in daily communication with them as well. And then around demobilization. So once the strike was called off and, we knew the next day the providers, we would be able to welcome them back and happy for them to return. We knew that we couldn't just send everybody away, all of our help, because, we had to just gradually return to normal operations. So we did have a transition plan to ensure that we always had coverage in the hospital just in case. So we continued all of the providers that were helping for the, towards till the end of the week. We maintained daily communications. We continued the rapid patient discharge after the strike conclusion just to make sure our volume stayed doable while everybody transitioned back. and James really created a very great demobilization spreadsheet around everything that had to be like switched back to normal operations, and make sure that we highlighted each of them and hit all of them. So it was quite a pre, during, and post response that took a lot of coordination. And next slide for you, James.
So again, something that we faced, I mean, you're getting a theme here, as you can see, all these different incidents, they're just incredibly varied, right? This one here is a hospital evacuation that we had to deal with back in September. So there was, I don't know if you guys remember, but there was a tropical storm Ophelia, which caused just a huge amount of rain. We got about 8 inches in something like an hour and a half, I believe, in September. So it caused huge flooding, right? A bunch of the subways were down, and a large swath of Brooklyn lost power, including Woodhull Hospital, which is one of our kind of smaller community hospitals located in kind of the Bushwick, East Williamsburg kind of area of Brooklyn. So what happened was the kind of the interface where Con Ed and the actual hospital kind of meet up was damaged by all the flooding. And so the hospital moved on to temporary generators and was able to sustain that, and was going to be able to sustain that for a significant period of time. However, after Con Ed and a variety of different kind of utility groups came and took a look at the damage in the building, it was decided that there was no way to safely switch from emergency power back to the regular grid while all the patients were still in the building, because it was not clear what was going to be able to switch over successfully and what was not. So the decision was then reached to actually evacuate the entire hospital. So we were fortunate in the fact that this was, we had a fair amount of time. So we were able to work, I mean, obviously very closely with Woodhull's, Woodhull's leadership and all of their team and their staff. But also we had a lot of time to get our ducks in a row, right, with all of the city partners that we were going to need in order to be able to evacuate around 140 patients is what we were looking at, overall. So we started by kind of on a Friday night deciding, look, let's get the kind of the most vulnerable patients out first. So that was transferring out ICU patients, right? Patients who are ventilated, as well as patients who were in labor and delivery and were expecting to give birth. So we, again, utilizing the fact that we are, kind of one cohesive system, transfer those patients kind of throughout our system, trying to keep them as close to home as we could. So a lot of patients went to Kings County, a lot of patients went to South Brooklyn Health. And then starting on Saturday morning, we kind of rallied the troops, if you will. Everyone knew what we were doing, so we were able to get a huge number of support of resources from FDNY. You'll see that that's a picture of what they refer to as their Me Too's, which is the Medical Evacuation Transportation Unit. It's a, I don't know how to describe it except for as like a very bizarre bus. Like the inside, it looks like a submarine from like the old like World War II movies. It's like totally windowless, and it's just stacks and stacks of stretchers, and you can fit 32 patients all lying down like nose to nose into this. So they lent us 3 of these. I think there's only 4 of them in the city, to help us move large numbers of patients. We took a couple of them up to Elmhurst, which was much appreciated. And then we also utilized our own ambulance service. So New York Health and Hospitals has an agreement with Ambulance to provide kind of I don't remember the total number of ambulances we have, but that day we had about 25 ambulances that were just dedicated to Woodhull and to moving the patients out. So the majority of the move, we got from starting at like 7 o'clock in the morning on Saturday until literally 12:01 on Saturday night. We managed to evacuate all of the patients out of Woodhull Hospital. They all went to other sites within New York City Health and Hospitals. We didn't have to go outside of the system. There was no safety issues. There was no adverse events. No patients had any kind of detrimental outcomes as a result of the transfers out. And then the hospital was then able to kind of continue the repairs, knowing that the patients weren't going to be affected by the underlying kind of facility issues. We managed to get the hospital back fully online within 5 days. And then at that point, we then, in a very kind of deliberate and organized fashion, started to repatriate the patients that had gone out. A fair number of them had been discharged, but we did bring back, I think it was around 45 patients came back from the other hospitals back to Woodhull to continue their care. It was at the time, as I said, we were very lucky that we had, this wasn't something, this wasn't a hospital that was on fire or that needed to be evacuated as quickly as possible. So we were able to do this in a very deliberate fashion. We were able to do it so slowly that the mayor was able to come and do a press conference there. And, again, we couldn't have made this happen without all of our partners, both within the city hall, but also throughout the system. So again, kind of showing some of the very different things that you see in emergency management, right? When we talk about all hazards, everything we've talked about here has occurred within the last 3 to 4 years, most of it within the last year, right? Outside of, the length of COVID. This is just kind of what the field looks like. And it's one of the reasons why you'll see there's a lot of kind of overlap between emergency management and emergency medicine, right? You have to be able to, in both fields, kind of prepare yourself for the unexpected, prepare yourselves for when things go very badly, very quickly, and have that kind of mental discipline, but also underlying training to respond to that, to be nimble on your feet, right? To recognize what resources you have at hand and how to really work best in a lot of uncertainty. To come up with solutions and to figure out problems, whether it's one patient or 140. Next slide, Ryan.
So kind of hand in hand with any of these, emergency management deployments, for lack of a better word, that we have, responded to, is the mental aspect of it, not only on patients, but on staff. And we have, coming out of COVID, really made us realize that we needed a comprehensive support system for the staff. A lot of secondary trauma and just a lot of mental anguish that came from it. So the system stood up a very robust Helping Healers Heal program, which is a comprehensive peer support program for hospital staff. And when I say peer support, I really mean peer support. So as wave one kind of started to come down, my chief wellness officer, who's on this slide, Susie Bentley, Dr. Bentley, and I just started doing debriefings, and we would just pull people out of their shifts, bring them outside, set up some chairs, and just let anybody vent and talk and try and just talk through what everybody had just been through. So these were a combination of one-on-one debriefings, group debriefings. We did wellness rounds in different areas of the hospital. The wellness team did a lot of team building events and created a lot of support resources as well from what they saw and all the psychological and emotional trauma that came out of COVID. Next slide. And our system chief wellness officer really coordinated with the whole health system in this piece of the response, including emergency management, Office of Quality and Safety, Office of Behavioral Health, and really created a centralized crisis support system, utilizing the ambulatory care leads, the acute care leads, the post-acute leads, and community care as well, and the system leadership in each of those buckets. So our quality departments, our patient safety, our Helping Healers Heal champions, our psychiatry and behavioral health colleagues, volunteers, patient experience, and really coordinated a robust response of peer support and behavioral health support to help everybody try to adjust and get back to as much normalization as possible. Next slide. And finally, emergency management resilience framework. So if anybody who knows emergency management, this is what we always talk about. So there's the different phases of a disaster. So there's the preparedness phase, the response and coping phase, the recovery phase, and the mitigation phase. So in terms of the psychological trauma that happens in any disaster, in the preparedness phase, obviously you want to work toward the training and skills and awareness building, the psychological and psychoeducation of providers so that they are, they have the skills in order to be able to be deployed when they're needed. Once the event occurs, obviously you need emotional support to those in distress. It's very important to normalize reactions and response. Self-care is very important. Expanding the response and resources to the staff and patients who need the support. Identify resource gaps and just continually, use the plan, do, study, act cycles to be able to see what's working, adjust, implement something different. Once you get to the recovery phase, the ongoing training and refresher training. They created acute and long-term treatment, building safer processes to meet ongoing needs. And then in the mitigation stage, pretty much focusing on what did they learn from the disaster? What could they do better? Creating concrete lines of communication, emphasis on sustained coping. So very robust piece of any kind of disaster response is this whole piece of the psychological well-being of staff. Next slide, Ryan.
So some of this I kind of started to allude to. These are kind of the different opportunities that are out there, focusing mostly on emergency medicine, right? Emergency management is a field that you can go and you can do a fellowship in, which I've done. It's a non-ACGME fellowship, which does allow a certain amount of flexibility in it. But it's also something that you can get into just through experience and living through it, right? As I said, there is a kind of a huge overlap between emergency management and emergency medicine. Most clinicians who are involved in emergency management are emergency medicine clinicians, although not strictly, but largely, right? We do have individuals who are involved in critical care and things like that. And then obviously when we're talking about widespread emergencies like, the COVID, that was every single specialty was called to it. But looking at New York City Health and Hospitals specifically, these are some of the opportunities that we have available to us. So the Mosaic program is a relatively new one. That's actually, I think, just been set up in the last year or so. It's really focused on trying to get individuals who come from kind of traditionally underrepresented ethnicities and backgrounds involved in medicine. Having the experience, really getting kind of a chance to see what it looks like and what medicine really is as a way of mentorship as well. And that's something we're really focusing on at New York City Health and Hospitals. And then these are all of the different EM residencies that we have here. So we have, with emergency medicine residencies, I mean, we can spend a second just talking about it in general, right? I mean, there's 3 years and 4 years. I think we're about split half and half between which ones are 3 years and which ones are 4 years. And this probably isn't the forum to talk about which one's better or what the one is or the other. Because we could talk about that for ages. There has been some, we'll call it recent fluctuations in emergency medicine when it comes to residencies and kind of the match, etc. The last 2 years have been kind of interesting ones. I'm sure you guys are aware because you probably spend way too much time on Student Doctor or whatever the new version of that is, the TikTok version of Student Doctor. I don't know. You know, last year we had about 500 odd unfilled spots after match day, all of which did eventually fill up through the SOAP. This year, from what I heard, it's down to a much more kind of what a traditional number of around 140, I think, nationwide, I heard, hadn't matched. So very different from last year. Trying to figure out why is for people who are more involved in education than I am. You know, there's a bunch of different trends, different thoughts about why the last couple of years have seen so much upheaval. There was actually a huge increase in applications directly after the first year of COVID when everyone thought that we were heroes. And then it kind of dropped down when everyone realized that we were all very tired. And now it looks like it's kind of going back the other way. So, you know, I know this is an interest group, and obviously you guys have probably spent a fair amount of time thinking about emergency medicine. I'm happy to take any questions about it. I know Laura is as well. This is a field that both of us love dearly. I, speaking for myself, but I'll speak for you too, Laura, wouldn't change in any other way. As far as my experience and my journey through it, it's not easy, but I don't feel like most things valuable really ever are. But maybe that's just because that's how I was brought up. Yeah, that's kind of our 2 seconds. We have a huge amount of opportunities. You know, if people are interested in shadowing at the emergency departments, coming and spending some time, getting more involved, there's lots of different opportunities out there. And, you know, also in emergency management as well. Ryan actually came and was interned with us at Central Office Emergency Management for, I don't know, what probably felt like a year for him, but I think it was only like 3 months. But I think we squeezed like at least a year out of work out of you, you know, and really kind of gave him the opportunity to, you know, to see different aspects of what we do, but also gave us the opportunity to have him do a huge amount of work for free. You know, those are also opportunities that are available to anyone else who's interested as well.
Well, this has been awesome. Thank you both so much for giving that presentation and sharing some wisdom, both from these lived experiences you've had responding to disasters, but also just in general on the field of emergency medicine, specifically emergency management, as an opportunity to go into within that. We've got just about 2 minutes left, so I'll open it up for any questions that come from people here in the audience right now. But for those currently here and those who might be watching this as a recording, if anything comes up, feel free to reach out to me, and I'm happy to pass along any questions or inquiries over to Dr. Salway and Dr. Lavicoli to get some further input from them. So any questions?
Yeah, and agree. James and I are always happy to answer questions offline. So,
there you go.
Ryan can funnel them to us.
Yeah, I stuck my email in the chat thing. Please do not.
Oh, in the chat thing.
Yeah, in the chat. Don't send it to any Nigerian princes or something. I don't want to get spammed.
Perfect. Thank you both for sending those here. We'll make sure that those are available for those who are interested in reaching out. Respectfully, of course, since we know you guys are both quite busy, literally responding to disasters.
Make our lives sound pretty interesting, man. My disaster right now is my 2-year-old screaming in bed, so that's probably where I'm going to go respond to.
That sounds pretty critical to me.
Mine's my 300 emails I still have to check. So exciting.
Oh boy, both of those things sound like very different, but equally traumatizing ways to spend the evening.
All hazards, man. All hazards.
All hazards. Awesome. Well, with that, you know, we've just reached the clock. So thank you both again for being here for this. We'll make sure that anyone who has questions can feel free to reach out, and we'll distribute this recording afterwards to those who signed up but couldn't make it. So really, really appreciate you taking the time.
Perfect. Our pleasure.
All right. Thank you.
Thanks, everyone.
Good to see you. Thanks, everybody.
Thank you so much, guys.